Hello, everyone. Thank you for coming. Welcome to NADO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's a pleasure to be with you this afternoon for another fine series of breakout sessions. Let me introduce today's session. This will be called Data Gaps and Linkage, using linkage to overcome data gaps. Our moderator will be GV Rao, and GV organized the session with Helen. So let me go ahead and bring them on stage, and we'll turn the time over to them to introduce our first presentation. Helen, GV, the stage is yours.
Thank you so much, Norm. And this is a great topic. I'm GV, and I'm a strategic growth VP at Datagaps. And this session, when we're talking of Datagaps, we have a kind of a name very linked to it. When we're talking of linking the data between different databases and to cover the gaps. But the data gaps that we do is a little different. We talk of the quality part of it. Thank you for this, and looking forward to the session. Helen?
Yes, this is a very exciting session. We have some great speakers, and let's get to the first session presenter, GV.
Yeah. We have Brian and Paula from Massachusetts Center for Health Information and Analysis. Over to you, Brian and Paula.
My name is Brian Beaman, and presenting today with me is Paula Millard. We are from the Center for Health Information and Analysis, or CHIA, an agency of the Commonwealth of Massachusetts. Today, we are presenting on a project and analysis our research team has been working on, the enhancement of payer type data in hospital case mix databases through linkage to enrollment data in all payers claims databases. Before we begin, our team would like to thank CHIA's Data Operations and Technology team for their hard work on collecting, cleaning, and providing the data used for this project and analysis. Today, we will go through the background of this project, including our data sources, discuss our methodology, some of our key findings, and conclude with some limitations and future research. CHIA collects and maintains the state of Massachusetts acute care hospital case mix databases. The case mix data includes detailed hospital submitted information, including patient demographics, admission and discharge information, diagnostic and procedural coding, provider details, and detailed charge information. In particular, CHIA collects payer data, including the source of payment, or insurer, the type of payment, or plan type, and primary and secondary payer status. As this data has been submitted by hospitals, the payer data has potentially not been validated, which is why we typically refer to our payer data in case mix as the expected payer. Potential issues with expected payer includes incorrect or missing payer data, data not available at the time of visit, or incomplete payer data. Our team sought a way to enhance the payer data in our case mix data by linking patients in the hospital data to insured enrollees in the All Payers Claims database. This project aims to enhance existing payer data in the case mix, provides an opportunity to more properly classify payer type for patients with missing or incomplete data, or for those who may have been misclassified, and allows for reporting more granular payer categories, such as patients who are duly eligible for Medicare and Medicaid. Next, we're going to focus on our data sources. First up again are our case mix databases. This includes 3 databases: inpatient stays from the hospital inpatient discharge database, observation stays from the outpatient observation database, ED visits from the emergency department database. The other data source for this project includes enrollment data from the Massachusetts All Payers Claims database, or APCD. The enrollment data includes first the member eligibility, or ME, which includes per member per month commercial, Medicare Advantage, and Medicaid enrollment data, restricted here to medical coverage only for this analysis. Second is the Mass Health Enhanced Eligibility Data, or MAHE. Massachusetts Medicaid program is called Mass Health, so for the purposes of the presentation, MassHealth and Medicaid may be used interchangeably. This file supplements but does not replace enrollment data from the ME. The major variables of interest from the enrollment data includes insurance enrollment start and end dates, insurance type, and a Medicare indicator for capturing dual eligibility. The linkage across databases was made possible by use of an enhanced probabilistic patient identifier. This unique ID creates identification to link unique people across organizations and databases, including provider organizations or different payers. The person ID is probabilistic, meaning that hierarchically leverages personal data to create this unique ID. This personal ID was leveraged using the Massachusetts case mix data and APCD, as well as ResDec Medicare beneficiary data. For this analysis, several indicators from the APCD enrollment for commercial, Medicare Advantage, and Medicaid in the ME and Medicaid and Medicare from the MHE were created. The case mix and APCD data were linked using the patient identifier. Since case mix data contains observations at a visit level and enrollment data contains observations at a member month level, the insurance indicators from the APCD were merged onto case mix based off the discharge date from the case mix that corresponds to the month of enrollment in APCD between the begin date of enrollment or the first of the month and the end date of enrollment or the last of the month. In addition to the enhanced probabilistic identifier, a small number of additional case mix visits were linked to APCD based off of Medicaid member ID. Lastly, due to a small number of multiple enrollment records, often due to enrollment in more than one plan, we deduplicated a small number of records by prioritizing positive indicators, or an indicator of yes for enrollment in a plan, and by sorting by prioritizing most recent records. At the end of our linkage, for each visit in the case mix, we have the following variables: any linkage to any enrollment data, Medicaid indicators leveraged from the ME and MHE, Medicare indicators leveraged from the data in the ME, MHE, and Medicare Advantage based on product type, dual eligibility using the above Medicare and Medicaid indicators, and lastly, a commercial indicator. For the purposes of this project, we did not use any primary or secondary insurance indicators from the APCD due to the limitations of these variables. Next, I'm going to pass it off to Paula to discuss some of the key findings.
To start with some background before we get into the graphics, we measured concordance of payer types across the databases. High concordance between the same payer and case mix and the APCD, and low concordance between different payers from case mix and the APCD demonstrate the success of matching unique persons across these databases. Regarding the following graphics, we restricted all graphics to Massachusetts residents only, and aside from the any linkage slides, the following graphics include only visits that linked between the databases. Additionally, outpatient observation visits were included in the analyses, but excluded from this presentation in the interest of time. This graphic details any linkage between the case mix hospital inpatient discharge database and the APCD. 2 out of 3 discharges, in blue, linked to the Massachusetts APCD out of approximately 750,000 discharges per year between federal fiscal years 2016 through 2022. These graphics show the percent of total hospital inpatient discharges by Massachusetts APCD payer flag. Based on the inpatient discharges that linked between the case mix database and the Massachusetts APCD, approximately 36 to 40% of discharges had any MassHealth. 17 to 19% were dual eligible, 26 to 28% had a commercial payer, and 18 to 23% had Medicare Advantage. For federal fiscal years 2016 through 2022, among discharges that linked between the databases, the MassHealth flag and case mix expected primary payer type had a 93.6% concordance. The commercial flag and the case mix expected primary payer type had a 76.9% concordance. This graphic details any linkage between the case mix emergency department database and the APCD. 65 to 71% of ED visits linked to the Massachusetts APCD out of more than 2 million visits per year between federal fiscal years 2016 through 2022. Similar to the previously shown graphics, these graphics show the percent of total emergency department visits by Massachusetts APCD payer flag. Based on the emergency department visits that linked between the case mix database and the APCD, approximately 68 to 72% of visits had any MassHealth, 17 to 19% were dual eligible, 23 to 26% had a commercial payer, and 6 to 11% had Medicare Advantage. For federal fiscal years 2016 through 2022, among visits that linked between the APCD and the EDD, The MassHealth flag and the case mix expected primary payer type had a 94.8% concordance. The commercial flag and the case mix expected primary payer type had a 77.1% concordance. Our findings match our overall expectations of payer types across databases. Some of our key findings were that Medicare Advantage was higher amongst inpatient discharges versus emergency department visits. MassHealth was higher for ED visits. About 1 in 6 inpatient discharges and ED visits were classified as dual eligible based solely on linkage to the APCD. And there was a high concordance between case mix payer and linked payer, in particular for MassHealth enrollees. Finally, we will review the limitations of this project and some future research goals. This project used APCD enrollment data and not information from medical claims that can be used for things like paid amounts. Additionally, due to the lack of mandates for commercial insurance providers to submit data on self-insured enrollees to APCDs, there are significant gaps in the availability of commercial enrollment data. Lastly, CHIA's case mix data only contain visits to hospitals in Massachusetts. Therefore, patients seeking care within the state but reside elsewhere will not link to the Massachusetts APCD enrollment data. Currently, we are working to include ResDoc's Medicare fee-for-service data to identify patients enrolled in Medicare. Our preliminary testing has been very good so far. Additionally, data linkage can be used to enhance demographic data across datasets. For example, APCDs with high degrees of missing race or ethnicity information can be linked to case mix data with low amounts of missingness to enhance data quality. In the future, our reporting will include a fully enhanced payer type variable utilizing all databases. Thank you for your time, and please feel free to reach out to either of us if you have any questions.
Thank you so much, Brian and Paula, for this insightful session. Just waiting for any questions from the audience.
I have one question for Brian and Paula, just until we get one from the audience. GV, I'm curious, in linking payer and provider data, what measures were taken to ensure the data quality and consistency, particularly given the potential for discrepancies in the enrollment data itself? Can you shed a little more light on that?
Yeah, I think that's definitely something that was part of the findings from the concordance, was to examine like how well the linkage was successful or not successful. And I think that was kind of showing the high concordance rate between the payer types, especially in particular for the MassHealth or Medicaid patients, showing that like the high concordance that like many patients that were in the hospital data were also being identified as having the Medicaid in the APCD as well. I think the thing for us to look into is where the patients are not lining up on our expectations and seeing like what might be the cases there. So I think that's what we're kind of this analysis is kind of relying on, is the use of this linkage to identify add another kind of quality check on the data that comes from the hospitals, because the data coming from the hospitals, I think that's just we just want to make sure that like it's been enhanced and validated. But I think that's the idea, is we were trying to get at like validation of the payer type in case the hospitals are reporting maybe the patient data was incorrect, whether or not the data is valid coming into us, but is the data correct at the end of the day.
Thank you. GV, do you have any questions or anything from the audience? I do have one more follow-up, but I want to make sure we get things from the audience.
Yeah. While we wait for the audience, how is it looking now? I have a question. So what would be the implications, right, of these findings on the payer policy? Such as because you see the Medicare and Medicaid programs, how can they be designed better so that you manage the frequent ED users and inpatient discharges, which are higher on both the Medicaid and Medicare?
Yeah, certainly. I think that for this, I think this provides an opportunity to more accurately classify who are these patients and making sure we're capturing the right people in particular, because we know that many of the public payer patients who are on public payers, in particular, some of the like especially like the the 18 to like 64, and usually in our analysis, the people that are under 65 who are on public payers have high frequent utilization. And so I think with this capturing, making sure to capture who truly are these patients and making sure that the data is not just accurate, but the most quality it is, so we can be providing estimates that best reflect these patients in these hospitals and these populations that are at high risk for frequent utilization or high utilization and high risk for utilization.
Okay.
I think I don't see any more questions, GV, so I think you could introduce the next speaker.
Sure. Thank you so much, Brian and Paula, for this. Linking up different databases and coming out with the insights, which will be useful both for the payers and the providers. It's an amazing lesson. We would like to look for how is it going to progress. Thanks a lot for your time today.
So I think the next speaker we would like to have, GV, is Britteny Matero.
Yeah.
Is that correct? Would you like to introduce?
Yeah, we're just waiting for Norm to, yeah, okay. Thank you. And we have the next session is on turning tides and maternal outcomes by Hamad, Husainy. And then we have Britteny and Kate joining them. This from PointClickCare.
Hi, my name is Hamad Husainy, Chief Medical Officer here at PointClickCare, and I'm really excited to share 10 minutes with you today to talk about bridging the gaps in maternal health. Of note, I'm an emergency medicine physician by background. However, about 7 years ago, I had the pleasure of being asked to join a committee in Alabama where I reside, the Maternal Mortality Review Committee. At the time, I was just being generous and nice to join this committee, but after 7 years, I can firmly say that it's probably the most gratifying committee that I serve on today, and it's the last thing I would be willing to give up. It was blowing my mind, the gaps in healthcare that exist between certain individuals, but both prior to pregnancy, during pregnancy, and postpartum. It's a real crisis, and I'm excited to share with you today how technology has helped close those care gaps in my state and others alike. So what is the big deal about pregnancy, and why do increased pregnancy-related deaths occur? Well, if we break it down into prepartum, or during the delivery and postpartum, historically, you've all heard the comment that babies have been delivered for thousands of years, and they're right, but it doesn't mean that these specific times come with complications. So when you look at the data today, about 1/3 of pregnant women die prior to, about 1/3 of women that die happens before the delivery, 1/3 during the delivery, and 1/3 after the delivery, which may not be intuitive, but it's quite interesting. And in my experience discussing these women in the Morbidity Mortality Review Committee, this tends to be true as these three different pods. And when you look at those that are of Indigenous and Black women, those of color, those that are minorities, those that are in a lower income, the gaps even get wider. And there's reasons for this, and I want to share today 2 opportunities that we have to improve this and places that we have. And so 50,000 women are affected daily annually by increasing their morbidity and mortality through being pregnant. So why are these rates so high? Well, I want to paint a quick picture for you. If you were a 25-year-old male with hypertension and you were seeing your family practitioner in an urban big tertiary care center, that had all the resources, but you were also, and that same person went to a rural community and saw a practitioner with much less resources. The care for that person is pretty standard. It's pretty consistent. While it's not equal, it's very close. But as we talk about maternal care, the gap between what is received in an urban or suburban environment, a well-to-do upper-class neighborhood versus a lower-class neighborhood, the resources are just incredibly widely different. And so anytime we have something like that exists, and maternal health is not the only one, there are others, what we see is a mortality rate that and a gap that is created, and it requires something above and beyond to close that gap. And I would surmise that technology is one of those avenues to do such. So let's talk about how this happens, right? There's really two major opportunities as I see it for maternal health. One is, how do we bring expert care to the quote ends of the country or the ends of the earth, and then how do we increase the visibility of patients that are being cared for without having gaps and blind spots in that. So how do we bring those experts, those perinatologists, those high-risk pregnant OBs, those even just those board certified OBs that have a very standard positive way for following a woman as she's pregnant, and then through the pregnancy, and then in the postpartum period? How do we connect the pediatricians and the mental health resources? How do we make sure that we are not all working in silos? But the reality is that if we attempt to try to train everybody, or train the trainer, train everybody in these rural facilities, in these lower income neighborhoods, the reality is that gap is going to continue. And so the idea of something such as telemedicine, being able to bring experts via technology to the periphery, being able to express and share their plans for what success looks like is one way. But being a technology company, I will share another way, and that's through increasing visibility. And that's something we've done successfully in Alabama, Nebraska, and other states as well, to be able to bring visibility into where a patient is traveling. And so if a patient ends up in an emergency department with hypertension at 2 a.m., the care team needs to know about that. That's really important, because if the care team doesn't know about that episode of care, what occurred was they're going to treat the blood pressure, and less than 12 to 24 hours later, that patient's going to be right back in that same predicament. And so they go pursue another episode of care, or we leverage technology to be able to connect the care team. So bring the mental health and substance use disorder resources together, bring the OB team together, bring the primary care team and the pediatric team and the emergency room, and all of these extra episodes of care, to be able to bring them into one place that's agnostic of the electronic health record or the location type, and really just be able to paint a picture and create continuity for these mothers. So when we talk about evidence-based practices, where are we going with this? We need ongoing care, not episodic care. I mentioned I'm an emergency room physician. I love emergency medicine. We serve a great need in the world that we live in today. However, let's not mistake from what emergency medicine care is. It's episodic care. It's not ongoing care. So what we need relationships. We don't need transactions. We need relationships with women and our patients that exist from the OB, prenatal, even prenatal screening, all the way through the pregnancy, all the way through delivery and into the postpartum days. Because, as a male, I almost sometimes feel a little inadequate to talk about this, but in some of our heads, it seems like once one's had a baby, everything is joyful and happy. But as we all are well aware of, if we've had children and with our partners and spouses, recognize that that's not always the case. And so we need a team. It can't be one individual, and we have to be able to have ultimate visibility into the time that these individuals are going through, whether it be pre, during, or post delivery. And then how do we bring that information and make it and socialize it within the care team, not outside the care team, but within the care team. So creating insights and being able to share that information in real time is really the best practice. I mean, wouldn't it be just absolutely detrimental that if a patient came to the emergency department with something that was really, really significant, a medical issue, a psychological issue, a social issue, and the next day they happen to have their one follow-up with their OBGYN and that information wasn't conveyed? I mean, to me, I can't think of something more catastrophic. And as I review cases of women that die every quarter within the Maternal Mortality Review Committee, it's motivating, but also frustrating to just sort of see the gaps in that communication where significant insights were created but not shared or made available to the care team. And the last thing I would say is, how do we just reduce the impact of chronic conditions? I mean, chronic conditions exist everywhere. They exist in all ages of life, the hypertension and diabetes. But when we see hypertension and diabetes in pregnant women, things just get exacerbated and the overall mortality increases with a pregnant woman who has hypertension or diabetes at baseline. So how do we make this more aggressively treat this? How do we become more holistic in our thought process of being able to treat these chronic conditions more aggressively, less aggressively, depending on the stage of life? And our OB partners really understand the need to be able to get an entire care team on board with treating these chronic conditions. And so recognizing them, being able to connect the whole team, being able to bring in endocrinology or cardiology for a slightly more complicated chronic condition than just a regular office visit that does not include pregnancy. And so these chronic conditions, in short, are just exacerbated across the spectrum with pregnancy and in the postpartum sector, the time frame as well. Well, I certainly appreciate the time that I've been able to spend with you today. I welcome any questions and thank you for what you do.
Thank you so much, Hamad, for that insightful presentation. A very pertinent topic. I'm looking forward to the questions from the audience.
GV, I have one. I know this was a very interesting topic because the birth rate in the United States and a lot of the developed world is going down and people are very concerned about it. So if we can somehow even positively interject in any simple format to alleviate that dramatic decrease in the birth rate is powerful. And I know Brittany and Kate will be answering the questions, but I did have one question before we get it into the audience, if you don't mind, GV. You know, sure. Many of the maternal health issues are really aggravated by our social determinants of health, food deserts now that we have and we see in inner cities, and the socioeconomic status of inflation and job loss and access to simple health care. How can linking healthcare data with all the social services that we need to also follow can help predict and mitigate any risk to vulnerable groups that otherwise should have a healthy pregnancy? So can you help us with that, Brittany or Kate, to better understand that?
Yeah, I love that question. And you're absolutely right. You know, even maternal mortality today, right? They say 80% of it is preventable. And these social determinants, they are impacting the care and the life. And we're talking about linkage of data. So, you know, for PointClickCare, they are bringing in the data around those social factors. Does a woman have, you know, non-emergency transport needs? Does she have housing needs? Is there a flag that says, you know, this woman has food insecurities? And so they're pairing that data with the health data so that there's that view that's accessible and ready and actionable for providers right there at the point of care, so that when they're in the office, they can see, well, you know, maybe I need to coordinate some of these benefits on behalf of, you know, this pregnant woman in front of me or this mother who has just given birth. And really making sure that when we think about care, we're thinking about how all of it plays together, both the physical and those social needs, and how do we make changes and improve that. And then, of course, then you can go up from there, right? And you can pull that data together and take a look at your populations. You can do hot spotting. You can see, are there certain areas where we are seeing, women that are impacted more than other areas. And so it's really being able to have the data available so that you can actually do something with it and understand it, and use it in a very meaningful way to change the trajectory of, what is happening and what is impacting these mothers and babies.
And just to follow up with that, Brittany, I think we try to force people, eat your broccoli, eat your peas, but some cultures don't have that sort of mentality to do it.
Yeah.
So not only do we have to collect the data, we have to actually compare the data to all these other factors that go into everyday existence. So I think, it's a very powerful conversation and something that we really have to keep our pulse on. So GV,
agree. And understanding culture too, right? Like in many of your Asian communities, you don't leave the house for 30 days after giving birth, right? And so how do we also think about culture and where it's relevant to bring in as well?
Excellent. GV, I'll hand it to you.
Thank you, Brittany. Yeah, I have one question, right? Care in itself is challenging, be it postpartum or even before that, right? Point is when people are working across states, right? They're accessing care across more than one state, right? Like you're talking of Vancouver and Washington, and then working in Portland. How do we ensure that this data is moved across the state lines and when it is needed?
Yeah. Again, I think that it's making data available to all of those that are part of the different care teams. So it is making sure that a woman's data and infant's data are following them for all of us, that our data is following us regardless of where we are being seen, that it's able to be pulled from national networks, that you have systems in place beyond just the EHR, that you have systems that are pulling in the information so that it's readily available. So one thing that PointClickCare does is they have what's called the Emergency Department Optimization Program. And so they do flags at the point of care in emergency departments. So if you are in Oregon and you're a provider in Oregon and your patient has an emergency department visit in Washington, the provider gets that, but also the emergency department physician gets a snapshot of what's happening in that mother's life. So they can see, oh, this woman just gave birth within the last, 120 days. I know that she has, the following allergies, and they're able to take action on the information that's in front of them because it's readily available, and it's as whole and complete and robust as possible.
GV, I have one more question followed before you introduce the next speakers. I was curious, the big thing is again about food deserts. I know I've traveled across the United States and there's some places where you could only get food at a 7-Eleven, get back and forth, or on, getting gas on the Mass Pike or whatever. How are you addressing, do you have any relationships that you're working with outside of healthcare, outside of the payer, outside of the government, but those social networks that people need? Are you having conversations with the food markets or the 7-Eleven stores? And if so, is there a positive reception, or that people just don't get how important that is?
Yeah, I mean, those conversations are absolutely happening. I think they're really being driven not as much by the technology vendors, which is where I don't think they should be driven by the technology vendors. I think they should be driven by community, right? By the providers that are in the community, by those social workers that are in the community. And we are seeing more and more of that happening. We're hearing about very innovative programs around how to get groceries. So are there ways, to get on grocery plans where healthy foods are incentivized for families and they're delivered right to their door? So lots of different, very unique ways of helping to address those needs. The same with like maternal care deserts, right? We have a lot of these maternal care deserts, and thinking about, like, as a community, how do we close those gaps? How do we ensure care? How are we thinking across with our food pantries, with our clinics, with our providers, and really bringing everyone to the table.
Okay.
Thank you. GV, it's all
That
yours.
was pretty interesting area to look at, right? I mean, I was just amazed when I saw the number of 50,000 women losing their lives in a year. That's a big number.
Yeah, it is a big number. And, when we think about the disparities as well between, the two Black and African American, American Indian, Alaska Native women, right? They're two-thirds times more likely, right, to have impacts in maternal mortality. There's a lot of work to be done, and it really takes all of us. And we need to be collaborating and working together, and we need to be really bringing data to the forefront so that we can do it in an informed manner.
Great. I think Norm has a question.
We'll hold them to the end, I think, GV, so we can get our next presenters in, if that's okay.
Okay. Thank you so much, Brittany. We'll be back with you after the next session. And the next session is a very interesting thing. It's about innovative reporting for Parkinson's disease and how to incorporate data about environmental exposures by the geographic residents. This is by Trudy Millard, Krause, from UTHealth School of Public Health, Center for Healthcare Data.
This presentation is about a research journey, an evolution of data exploration, and most relevantly for this topic session, about responding to data gaps. This is a project we started at the request of a Parkinson's expert at Dell Medical School who was interested in exploring whether environmental exposures were factors in the development of Parkinson's disease. So to give you a bit of background, Parkinson's disease is a progressive and debilitating neurodegenerative disease. It affects about 1% of the population older than age 50, and its etiology is not fully defined. Researchers are now beginning to suspect an association with both genetic as well as environmental factors. And they're looking into environmental factors such as pesticides, certain chemicals and industrial solvents, air pollution, and exposures to toxins such as metals. So we wanted to start out by taking a look at what was the prevalence of Parkinson's disease in the state of Texas. We're using our Texas APCD data, and we wanted to report it on a per 100,000 level, which is a prevalence rate. And we started out by looking at it on public health regions. Texas is a very large state. We have both very large metropolitan areas as well as a lot of rural areas, farming communities, and other counties with less population. We found, when we were looking at people over age 50, a total count of individuals with Parkinson's disease in our Texas APCD data of about 110,000. Medicare fee-for-service represented 56,000 of them, commercial and Medicare Advantage about 50,000, and then Medicaid duals were about another 3,000. Because they were all over age 50, our average age was 68, and males and females were pretty evenly distributed in the population. One of the things that we were quite excited about was this was one of the largest Parkinson's cohort studies that we could find in existence. Other studies we found, the next largest one with a population size was done by the Michael J. Fox Foundation, and they had 30,000 individuals. So with 110,000 individuals, we thought we would have some very interesting results. So I copied our rate of prevalence of Parkinson's disease over here on the left-hand corner for reference. Now we're going to take a look at what we found in our linked data on environmental exposures. Starting with paraquat, which is a common pesticide used in farming communities. We found, and I'm reporting the rate again by public health regions, you can see that the upper left-hand corner of the state had the highest region by far of the rate of pesticide exposure. This is a very rural area, a very large farming community. Next, we look at chemical exposures on TCEs, and the areas that have no rate shown in red had very insignificant or low rates of exposure. But you can see in the area highlighted, a really, really high rate occurred in the right-hand corner of the state, especially compared to other public health regions that are reporting their rates. This rate is really reflective of the Houston Ship Channel, which is where the petrochemical industry is based, and also where our one of the largest ports in the nation is based, and it's where a lot of chemicals are shipped out of through the port. Next, we looked at air pollution, and you can see the highlighted areas that stood out are entirely different public health regions. So overall, what we saw in just direct observation of these rates and compared to our prevalence rates is that there really didn't seem to be much correlation. So we decided, well, we probably need to take a look at this differently and maybe reassess what we're trying to research. We decided that our APCD data may not be sufficient and have sufficient information to really evaluate the development or what factors lead to the development of Parkinson's disease. Our data in the APCD only comes from 2019 going forward to the current date in 2024. So we thought, well, let's revise this and take a look at whether the area that a Parkinson's disease person lives in, whether exposure in that area contributes to progression of the disease or different types of symptoms of the disease. So we went back to the literature. We found a really well-received study by Hone and Yar, and that defined 5 stages of Parkinson's disease. They based these stages on a level of clinical disability, and the levels ranged from early to debilitating, as you can see on the table provided on this chart. And each of those levels then defined elements, which they refer to as elements, but we translated into symptoms. And we took those symptoms and then went back into our medical claims and found those symptoms in the diagnosis codes and assigned those to each of these levels. We then supplemented it by also using HCPCS codes, which would help us identify the mobility aids, such as wheelchairs and walkers. We also added at least one procedure code, which was related to deep brain stimulation, which is used for Parkinson's patients. And then we also added place of service codes so that we could identify individuals who were living in assisted living facilities, nursing homes, or needed attendant care of some sort. After that, we still found that there was some ambiguity and crossover between severities and the level assignment. So we decided to condense them into 3 basic levels. Level 1 and 2 became identified as an early stage. Level 3 became mid-stage, level 4 and 5 late stage. And you can see how we condensed also the symptoms in each of those stages. Level 1 and 2 were the early symptoms of tremors and other movement disorders and speech disabilities. Level 3 became where gait and balance issues were displayed, and that's also where deep brain stimulation was commonly used as a treatment for these symptoms. Level 4 and 5 became much more mobility-related codes, requirements for attendant care, cognitive issues, and possibly dementia. After doing this, we still found that nearly 11% of those individuals with a diagnosis of Parkinson's disease could not be assigned to a level of severity. So next we turn to the pharmaceutical claims. The standard pharmaceutical treatment for Parkinson's disease is a drug called levodopa. And this drug is very effective in treating and containing symptoms, although the dosage does vary as the symptoms emerge or worsen. And so there are studies that will assign the dosage of levodopa to different levels of Parkinson's disease. One of the complications we ran into, though, is that there are other drugs used besides levodopa that are treating Parkinson's disease. They are considered levodopa equivalents, and there are some research studies that have translated these levodopa equivalent drugs into what's called as a levodopa equivalent dose that can be used for these type of research studies. We found in our claims data, pharmaceutical claims data, that there were, when you looked at these levodopa equivalent drugs and their variations in dosage, strength, and frequency of administration, there were 32 different variations that had to be assigned some logic to create a levodopa equivalent dose. Once done, then we applied that to the same methodology as levodopa and used the literature defined severity levels based on drug assessment, which are mild, moderate, and advanced. And those 3 levels overlapped quite nicely to the previously defined 3 clinical levels. So our next step is to go back to our database and identify the individuals with Parkinson's, use our 2-step methodology of medical claims and drugs to assign a severity level. This severity level will be assigned on a month-year basis so we can start to track changes across time. We made the decision that once a higher level is identified, that individual will not regress back to a lower level, even if the symptoms are contained, that they always will stay at that higher level until they progress to an even higher level. So from here, we are planning on working with our colleagues at our School of Biomedical Informatics, who will take our information, our methodology, and apply artificial intelligence to test it and to help us improve this logic and these methods. After that, our next step is to circle back to our original study. And even though we've decided we're not going to look at what contributes to the development of Parkinson's, we're going to start looking at whether the geographic location of an individual with Parkinson's disease makes a difference in their disease progression or their symptoms, emergence of symptoms. So to do that, we have to find and define an expected time level for this progression from between levels, and then start looking at that on a geographic basis. We will use our data in the APCD, which has very specific geographic levels down to zip code level, as well as the environmental data that we're receiving from other sources, which goes down to a county or a zip or a census tract level as well. So we'll become very refined on our geographic area. Ultimately, this amounts to a longitudinal study, which means that we're studying these individuals across time to see changes across time. And we're using and linking our Texas APCD claims data to environmental data from other sources so we can assess the impact across that time span. So in summary, this is a really interesting study to us. It's an example of finding data and data gaps. Our key gap initially was that our available data was determined to not be sufficient to really answer the original research question. And as we found gaps in the data, we had to find innovative ways to fill those gaps by either modifying the data, improving the data, or supplementing the data in different ways. As an APCD, in Texas, we're one of the largest APCDs. We have a vast amount of valuable data, and this data can be used to conduct clinical and population health research. We feel that we have a need to find ways to expand upon this data to really enhance its value for this purpose and its use. And population health research is one of the defined objectives of the Texas APCD. So in summary, I want to provide thanks to those people that are participating in our study. Dr. Eric Krause is a physician at UT Dell Medical School. He was our Parkinson's expert. Chao Trong, Sulki Park, and Xiaori Zhang are members of my research team. They are data scientists and biostatisticians. Thank you.
Thank you, Trudy. That was an amazing research that you're doing. And I see with a longitudinal study, it can be used for multiple other areas, right? I just want to understand how, when you're looking at Parkinson's, the same thing can go for cancer, it can go for anything, where the environmental factors might be useful. Yeah.
Yes. Yes,
Okay.
it can.
I have a question for you. So once you had identified a patient severity level based on medication dosage and compared it with the doctor's prescription or a procedure-based levels, how many patients were still unable to be assigned to a level?
Yeah, thank you, Zev. That's a really astute question. I'm glad you asked it, because we did still have a number of people that were unable to be assigned to any level. And so we went back and looked at those individually to see if there was any reason that could explain why they weren't assigned. And actually what we found is the majority of them really only had a single diagnosis of Parkinson's. And we believe that that was probably a rule-out diagnosis. And so we went back and revised our study criteria that they had to have at least 2 Parkinson's diagnoses to be included in the study, which would start us then on looking at the symptoms and the drug use to assign a severity level. So that was really an interesting finding for us, and I'm glad you found it right away.
And I have one question, Trudy. Thank you so much for that, again, excellent presentation. I guess it's from a global perspective. You know, everybody's talking about AI and how it's incorporating and helping everyone analyze data. But, you know, AI is programmed by humans in and above themselves. So there's a somewhat of a biased nature when we are programming AI. But can you explain more about how you plan to use it in your current environment and what you're seeing, if at all, currently with the data being maybe pushed through an AI program?
Yeah, thanks, Helen. As the APCD, we have been getting a lot of requests to use the data for various AI purposes. And so we knew this is something that's coming, that it's going to happen in the future, right? And given how we were sort of stymied in our study, and that we came up with this logic and this algorithm for Parkinson's disease, we wanted to find a way to validate it and improve it. So we thought, well, let's turn to AI. So this is really our first entry into the whole AI process. And in working with our School of Biomedical Informatics, the first thing we decided to do is really more related to machine learning. And what we're going to do is we're going to take that group of patients that we've already identified as Parkinson's. We are listing on each individual all of the diagnoses of symptoms that we found. We're listing the levodopa and levodopa equivalent dosage rates and any other information on that patient that can be done in a simple sort of spreadsheet on a patient-by-patient basis. And then we're asking a team of Parkinson's experts to pair 2 of these patients. And we're going to give them like 10 to 20 pairs. And they have to make a clinical decision. This one would be at this level, and this one would be at this level. And then list why they're making those decisions. Then our School of Biomedical Informatics is going to insert that into machine learning as a way of incorporating clinical decision making. And the machine learning will decide, well, okay, this is what it looks like for clinical decision making, and see if they can then put it into our model and refine it again. So we're really kind of excited to see what happens with that.
You may not answer it, but what are the kind of models that they're using? The models for AI?
Well, this is a machine learning model, and this is not my field, but I do know there's a name for that model that he's using, and I could get back to you on that.
That
would be great. That would be great.
What were the challenges in linking environmental exposure data with individual medical claims data? I was just curious.
Well, we have not been able to do it yet because we wanted to study was that environmental exposure impacting the progression of disease. So we had to have a way of identifying progression of disease first. But once we do, and we're pretty close to doing that, we'll be doing it by linking it with some sort of geographic identifier, a zip code, a county, census tract, whatever it might be. And we have all of the environmental information from other sources, and it'll all be linked by that geographical component.
Okay.
Let's bring everyone back, GV, now. What do you think?
Yeah,
and open it up to some questions.
That's good. Thank you so much, Trudy. That was a very insightful session. I look forward to the research that you're going to take it forward.
Yeah. I actually saw one question, and then I know there's some in the chat box too, GV, but I wanted to ask Brian and Paula, it escaped me with the question, but I think it's important for the audience to understand this. Medicaid enrollees oftentimes don't have that follow-up with the primary care doctor, and they show up in the ED for services, and they fill up the beds. They don't have that follow-through of their care. Do you have any insights, Brian and Paula, about, informed policies to improve the Medicaid patients' access across the healthcare continuum? Can you shed any light to any of that?
Yeah, I think that's definitely some of the research questions that that people on our team or just other people at CHIA have been interested in just looking into. Has been following people in terms of their continuity of care. Are they getting the primary care visits, or are they beforehand, or potentially examining potentially avoidable or types of care that were seen in the emergency room that could have been treated potentially in maybe in primary care or even in an urgent care setting. I think that's definitely something that our team has been interested in, topic of interest, and then examining. We definitely know that, based on the research that we've seen, that the public payer population, especially the Medicaid population, is definitely the highest affected of those. And so I think that having just the best data possible, and then the best and enhanced clean data to make sure you're having the right population, to make sure you to examine that, and make sure you're focusing on the right populations to get to get to those findings. And I think that's definitely something that our team is thinking about, not just in terms of just payer linkage, but also just who are the people that are utilizing the healthcare, and then what disparities are potentially at play when it comes to between like different patient characteristics, including like the payer type data, which payer type often can sometimes be a proxy for other social determinants of health.
Mm-hmm. Great, thank you.
We have a question from Colin. Have you seen deployed use cases where SDOH data is inserted into the actual provider operational workflow? And there's a lot of discussion around.
Yeah. So I think when it comes to the use in clinics of SDOH data and patients, I think that we see a lot more data capture by providers, leveraging like the USCDI codes that are in the EHR. Where we really see the use of data coming in around SDOH and that patient is more around the case managers that are embedded in the clinics themselves. So a lot of FQHCs now, they have care managers specifically for their maternal health population, or they might have various duties, but that's part of it. And they certainly are looking at that information and using it. So one example is in Nebraska, some of the FQHCs in Nebraska, when they get notification that their patient has had the baby, they take a look and they see, what can I see here are the needs. And they actually have been working with programs there locally to do things like, do they need assistance with diapers? Do they need maybe they don't have really good transportation? So can we go and visit them for their care needs where they live, or send like mobile breastfeeding support? Do they need vouchers? So they're trying to think about, the data that they see that they're getting either through ICD-10 codes being captured in the EHR, or using platforms like PointClickCare solution, where there are flags and notes and things that relate to social determinant of health needs. And then they're closing those care gaps through that case management role within a clinic, or someone who is doing those functions more so than providers themselves.
Wonderful.
I love that question.
That's great.
Thank you so much, Brittany.
I have a quick one, GV, for Trudy. Just off the cuff, Trudy, why did you cut off your analysis and your research or your program at 50?
Well, age 50 is usually the point where it starts to emerge. The Parkinson's disease most often occurs after age 50. Although, according to our expert on Parkinson's disease, he and others across the nation are starting to see it more and more often in younger populations. So I think that will be something we will again add to our study when we start looking at exposures. We might start really looking at incidence rates in the younger population. It's harder to look at the incidence rates in the population we have right now because our data doesn't go back far enough. But if we can start looking at whether it's impacting the younger population, and again, in those areas of environmental exposure, it will be a very interesting add-on to our study.
And I think it's very important, Trudy, because now we're coming into this, let's talk about getting healthy and let's try to get preventive. So maybe there's these little cues or signs, maybe 5 years before you actually get that diagnosis, that you can do something. And I think we got to start hitting those conversations earlier on versus, okay, now you have the disease, now let's track it, versus was there some intervention we could have possibly done? Maybe not, but those conversations got to back up. So I'll be excited to see how you can transpose that. And maybe there's these warning signs that we would all want to share.
I agree completely. And I think that's one of the unique advantages of having some very comprehensive APCD data, because you can go backwards and look at, were there some presenting symptoms beforehand that may have been missed in any disease. And so I think that's a really great opportunity for study.
We're talking about data and linkage, right? In linking, we have a payer data and a provider data. So what are the measures that we are taking to ensure the data quality and consistency? knowing very well that there are discrepancies in enrollment data across the databases.
This question for us, I believe. Oh,
Anybody can answer, right?
Oh, yeah.
Everyone is doing the same thing.
So I think with that is that like one step is just the data quality coming in the first place, is like the data populated, and that's the first step. And I think that's a step that like on other of our data operations and technology team to take the data. So taking in the data is one step, but then kind of making sure that like when the hospitals are submitting us to the data, are they submitting us to the data that like is like on the surface level seemingly correct, or not correct, but valid, so to speak. And so is it in the expectations of, or should you see a high share of self-pay of people on reported self-pay at a hospital? Or are you seeing a lot of patients who may have like a slightly elevated amount of other? And so I think that's where it comes into play, where like linkage, like it's usually like hospital specific examination of, are the hospitals over-reporting or under-reporting what we might expect based off of what we know about that that hospital in the state.
GV, I think it's a closing. So
Okay.
you close everyone and thank everyone.
No, thank you, all of you, right? All the three of you. It's been a great session. I definitely would like to continue be in touch with all of you and looking at how your research is progressing and what is the next steps in all of our different areas, be it in the maternal, be it in the Parkinson's disease, be it on the case mix part, which Brian and Paula are working.
Yes, and
Thank
the
you so
next
much for your time.
our plenary session, so everyone continue on with the exciting presentations for NATO for our 2024 annual virtual conference.
Thank you so much, Helen.
Thank you, everyone.
Thank you for having us.